We will now go on to the talk by Dr. Anand, and then we can take the discussion for both the talks after Dr. Anand's talk.
Thank you, Dr. Diksha and Chandigarh Ophthalmic Society for this opportunity. Firstly, for those of you who remember, this was the weekend where the World ROP Congress, which the Indian ROP Society was going to host, was supposed to happen in Dubai. And yes, we are not there, but we're celebrating it with an ROP seminar here. So thank you so much. And also for me, it's an extremely proud privilege to present in a meeting where the chair is none other than Professor Dr. Dogra sir. And on Teachers' Day, he's been my teacher, and I owe almost everything I know in ROP to him. So thank you, sir, and thank you once again for the opportunity. Well, Diksha has given me this topic of what constitutes an adequate laser treatment for ROP. So I figured I'm going to do this mostly in terms of cases and not really dwell on theory. So I have a lot of slides, but not to worry, I'm going to really move fast on them. So laser is still the gold standard, has an extremely high success rate. Sir showed that the 532 nanometer green laser can be used, in fact, more effectively than diode itself. And ever since, the whole country and the rest of the world has also been using that. It's important that all of us have been trained to do laser under topical anesthesia, but take care of analgesia. These pellets that we soak in either dextrose or sucrose really calm the baby and help to do the treatment. These babies have to be swaddled well, and I'm just going to move quickly on this video. The importance is to separate the two hands and the 2 feet separately in the folds. And yes, since we are putting a pulse oximeter on one of the on a foot, we have to expose that one part. Remember also that the drops that we start putting on the cornea to keep it moist during laser tend to accumulate on the cloth and can give rise to hypothermia. So that's something we need to keep in mind. The ideal height is about 1 palm distance from your umbilicus. Should be about the nose of the baby when it's lying supine. This is the most ergonomically right height so that you're comfortable, your neck is not craned, at the same time you are able to visualize easily. Never count the number of spots. The idea is to do a good job, and by good job you mean all the ischemic and the avascular areas. Sometimes the ridge is involved only in about 6 clock hours, but you end up lasering 360 degrees if even the nasal side or somewhere else has avascular retina. So that's really the key thing. Tunica vasculosa lentis is not a contraindication for laser. Sometimes really small pupil because of TVL, just with a massaging, going around it once or twice when you're examining clinically, dilate the eye well enough to complete laser. Diksha also mentioned this. Sir is very well known for this technique that he showed, how we can treat through the incubator wall, and I've had the opportunity to do that a few times after I've left PGI. Now, in the APROP principle, this is probably the one time when you want to stage the treatment. You can either laser on the flat new vessels that Dr. Subina showed. It can give rise to pedicle hemorrhages, or you laser up till the flat NV and wait for a few days, a few weeks, sometimes wait for the NV to retract, and then the ischemic retina is taken care of. For example, in this picture here, you see the laser marks here healing. It's about a week later, and you see this boat-shaped NVE that has retracted closer to the macula, exposing this ischemic area. And that's what you need to go and cover and overline the NV as well to give a good result. Now, here are some broad principles on how we do laser. Now, this is obviously a case of APROP. When you are training or when you're doing it initially, again, an angiogram here shows that the fovea is vascularized. A good idea is to mark out a safe posterior zone. You may go even more posterior, but this also helps the pupil to dilate. And then one good idea is to mark the ora serrata, as you can see in this picture, and then go on quadrant by quadrant and do a thorough job. So leave no area. And just a week later, it does well. If you've not left any skip areas, the plus comes down. Then you can evaluate and see, are there any more posterior fill-in that you need to do in this picture about 2 weeks later, just a small amount of fill-in, and these babies end up doing really well. Here's a tunica vasculosa. This is not the worst TVL. I'll show you another worst case, but the media is bad for whatever reason, and that's part of the APROP syndrome. Here also you see fibrovascular kind of proliferation. So this is not the ideal case for anti-VEGF because it can lift up and detach some more. So well, I chose to do laser here. Again, you can see that the D-shaped or the inverted C shape of ischemic retina is still left behind because you want to preserve as much of the retinal real estate in the temporal side, whereas everywhere else you need to be very aggressive, as you can see in these pictures. A week later, you start recognizing that everywhere else is doing well, but you probably need to do a posterior fill-in. It can look really ominous even after it's doing well, as you can see in this picture. But if you are sure and thorough in your laser, just another 2 weeks later, this is the picture and it does extremely well. Well, there are cases in which the angiogram will show that even the macula is not perfused, and these are possibly the cases where you want to give an anti-VEGF. There's a separate talk on this. So I'm just going to show you that weeks, and here in this case, months after following up this baby after anti-VEGF, the vessels have simply not reached the ora serrata. And we know this happens in many cases. In fact, less than 40% of cases probably reach the ora serrata. So this is 2 months later, and this is 10 months later. When we do an angiogram, you still see a very active frond and still some leakage. And now you know 10 months, the baby is really big, and this is when you might need to do a laser. So mark out the posterior border. Again, as Dr. Subina mentioned, an angiogram is not a must, but it really helps in these cases. So mark out your posterior border and then go ahead and fill the rest. And that's when you can, and then now it's a finality. This is when it does really well. I know Dr. Gaurav is covering a combined treatment, so we let him deal with that. Now, you don't always have to do a posterior fill-in. So here's an example where you do a laser here and you leave out some amount of the temporal area and revisit this case a week later. If you have done a good job not having any skip areas, then sometimes you never have to go back more posterior. Of course, this has to be individualized and it's not one rule fits all, but these cases do extremely well, and a long-term follow-up has shown that there is no residual ischemia in that area. Okay, so this is a photograph of really poor media because obviously the APROP is bad and the media is hazy, but and you know this is a case of APROP. Here's a small pupil, and the angiogram shows a really bad disease. Again, there was proliferation on both sides, so it chose to do a laser. So what I'm showing here is a posterior laser, the laser posterior to the ridge. Now, this has become a commonplace thing. Anna Els first described it. So I'm trying to show you that despite this small pupil with a massage and a bad looking ROP like this, you can get a good outcome after laser. So I'm just going to share a few consecutive visits. So here's a thorough laser, but yet, and look at the pupil dilate just 2 weeks later. So you know that your laser is responding. Now look at the media improve so much. In the superior picture here, you can see a bit of the traction still left and all the other laser healing. So here you want to go and fill in nasally as well. You want to add some more laser posteriorly. And when you do that and you follow up this baby, this is another 2 weeks later and another 7 weeks later. And the outcome in this case, as it is in many cases, if you do a thorough posterior laser and then fill in that gap, is a very good outcome. So here there's absolutely no residual traction. The one floating picture that you see in this nasal side is a vitreous floater, and everything else did really well. And bilaterally, both eyes. This is a case of anti-VEGF, again, followed up, and you can see also for some reason a congenital scar. So that has nothing to do with the anti-VEGF or the disease, but well noted. And you see the active frond, and this vessels haven't gone further months later and had to be lasered. Posterior zone 1 or zone half, as Dr. Subina mentioned, well, this was an obvious case for an anti-VEGF. So it was injected, in fact, in another center and sent to us. And then this had a very early posterior recurrence. We did not do an angiogram on this case. It was very obvious. The child was fairly sick, but we completed the laser and it does well. Now, I've sort of bifurcated this picture here. This is the right eye and the left eye. I want to show you that if you don't do a posterior laser in indications that it's required, that is a raised fibrovascular proliferation, well, the rest of the laser may heal, but there's a lot of traction still. So this is called a secondary posterior laser. That is when you've not planned it the first time, but you're doing it another time in the next episode. They don't always do as well as if you've planned it the first time. But still, as you can see in this case, it did well. In one eye, the traction completely went away. This is the left eye temporal. But in the right eye, there's still some residual. This child was seen only last week, and we've added more laser to this eye, and we hope that we'll eventually probably reach the left eye status. Buying time or avoiding surgery in 4A is also something. So this is a classical 4A. Perhaps in the OCT, it might even show a 4B. And you can see the nasal retina is completely detached for more than 4 clock hours. This child was unfit for surgery. So you buy time by doing a posterior laser, and just like how we do in adults, a barrage laser as well. So this is another indication for laser. And you do that to a point where you can see this traction retracting. A lot of this traction is exudative component as well. And that's what goes away. The true traction may actually remain, but we know that residual peripheral traction remaining sometimes doesn't do any problem. So here's the temporal side completely flattening, and nasally we still have some of that. Here's just one example, I think my last case, where after so that you leave out some amount of that temporal retina as I showed you, but you know very well that this area may need a fill-in. So look, when you first leave it out, there's a fairly large area and you don't want to go into the foveal zone. And this PMA is around 34, 35, so the foveal area is not developed. You wait for a week or two, the rest of the stuff heals, and now there's a much smaller area that you need to go into, and also the foveal reflex is developing. So you can see that if you stage that posterior fill-in, it does much better. So to summarize, cover all avascular regions, plan AP-ROP laser in stages, whether it's naive or post-anti-VEGF, and the posterior laser that I spoke of, either primary or secondary, is something that's becoming a new thing to do. Thank you very much.
Thank you, Dr. Anand sir, for a brilliant presentation covering all the fine nuances of laser in ROP, because for a good laser, what he has covered, it is so essential that you cover the entire avascular retina, and very important, as he showed, that you delimit the posterior most part and also mark the aura, and then fill in the area from your posterior mark to the anterior mark. Cover the entire avascular retina. It may require staged treatment. So it is very important that you call the baby back in a week or so, and then if required, the media may improve. You may get it, if in the first sitting the media was not so good, you may get an opportunity to complete the laser well. And if you saw the photographs, he showed how laser was applied in aggressive posterior ROP within the vascular loops. That is also very essential. And in very posterior disease, to delimit the boundary of zone 1 and then proceed with the laser. Thank you very much, sir. I now invite Dr. Dogra for his comments on these two talks.
Thank you, Anand, for excellent talk, as well as Dr. Svina here. And Svina covered the entire spectrum of what we need to really do with what kind of ROP. Type 1 referral warranted very well. I think she touched some of the things which are so important, especially about the referral warranted, which she picked up about the retinal hemorrhage, stage 2 disease, as well as if you have such a case, I think they need to be referred. Sometimes we get late and we have a problem. I must say here why I want to share, because many people are listening, especially general ophthalmologists. I think we somewhere, we are lacking in recognizing a serious disease where sometimes the vessels are not that much dilated, the retina is avascular, and we have seen at least, and we are seeing more such cases where they go on to develop real bad disease, and sometimes it is not even amenable to laser. So I think one need to really look at these retinas. If you are not, I think it becomes a referral warranted. It is even sometimes from a very well-known retina persons, perhaps they don't recognize this. So not that all the time. I wanted Subina to touch this point also, not that all cases would have a dilated vessel, especially a very posterior disease sometimes doesn't have a dilated vessels. And those cases are the one where a lot of mistakes are done, because that is not really the plus disease. And the person keeps on waiting with that, and they keeps on telling. Sometimes they even call, they talk, no, sir, the disease is very mild, and it is probably a vascular retina. But then that is where we go wrong. I think it's very important to even look at that part while we are screening these patients. And Anand, as always, he did excellent job. he would remember, I would tell those days even, that what is important is a confluent laser, that we have to do a confluent laser. And I feel so good that this concept, which we had always right from the beginning, has really, really helped preventing progression as well as regression of ROP in many cases. The way he has described how to demarcate the entire retina, so important. Even when we are in a teaching institute, how important it is. Let them remain outside that demarcated area. They will always remain outside. They'll not come out inside. And so is about those very much loops. Even when we had not done angiogram, we always thought that these loops are probably avascular. And talking about the laser posterior to the ridge, I think I must comment here about Gaurav, especially saving two children of ophthalmologist, doctor herself. The whole family was crying with me. I think we had some problem, and I sent to Gaurav across that time. And he did posteriorly, and they regressed very well and very severe disease. I think so. All these things, factors we have to take into account. And if we do laser, we must do laser well. And this is another problem I want to highlight again here. A lot of other retina persons must be there, general ophthalmologists. They feel very satisfied just doing some kind of inadequate laser. I'm putting inadequate laser here. I'll not even say some. And that inadequate laser is very dangerous. If you do anything inadequate, that means you have done more harm, because that baby will not be brought to another person who deals with ROP more often, and it will lead to the real bad consequences. So I think those kind of things, we need more people to be trained. As far as the screening is concerned, they need to be told about the other nuances. We should not feel satisfied that we know everything. And so is about the laser I talked about. Inadequate laser is not uncommon. And of course, sometimes we may go overboard, for which Anand nicely showed that barrage. I used to show once one slide where it had gone through the macula. I mean, I used to get, my heart used to almost stop looking at that one. But that is also one another extreme which may not happen. So I think great talks, as well as I'm happy all points have been brought out. If anyone has to add something here, that will be a great this thing, because screening and laser treatment are two aspects which are the most important. That is why it is so important for us to. So anybody else wants to?
There are two actually audience questions for these two talks.
Yeah.
And, Dr. Amit Jain from Mumbai wants to ask Dr. Anand that the temporal avascular area is usually wedge shaped, and if you try to make an inverted C with laser, one may end with laser in the vascular retina. If it's not inverted C, it results in probably a refractive error. So how does one go about it?
So Dr. Ajay, you're right, very right, that it's most often a wedge shape. The inverted C is really something that you need to do for APROP. When there is no delineation or where the disease ends, it's very ill demarcated, and you have to create your macula, so to speak, or your posterior pole, especially if you're dealing with a baby less than 35 weeks of postmenstrual age, when the foveal reflex is far from ready. So you can't do that 2 disc diameters kind of equation because there is no fovea. So that's when you need to do the inverted C. For the normal, regular, classical ROP, the type 1 ROP, you don't have to do that. You just follow the ridge. What I do here is I give a very smooth contour. I just join the two wedges with a slight curve. So when you get a smooth C, I've compared two cohorts where you get much lesser refractive error. And you're very right. If you start going into the posterior pole with a wedge like this, you're likely to have much more myopia. So you don't need to. So it's only for the APROP that you want to do the inverted C.
And there's one question, thank you, Dr. Anand. And there's one question for Dr. Subina. Dr. Shweta from Panchkula wants to ask that if the stage is there and a comprehensive ophthalmologist is following the baby, for how many weeks should he or she follow?
No, they can follow till complete vascularization also. It is only you should refer once it is referral warranted ROP. Once the patient, supposing you are seeing avascular retina, ultimately, like if it's zone 2 avascular, you'll call the baby at 2 weeks time. Zone 1, you'll call at 1 week time. Zone 1 is usually, they don't regress, they go on to ROP. But zone 2, yes, many of them regress. You keep on following, and once you are sure for 2 visits, the peripheral thing has been fully vascularized, you can stop seeing it. That's it.
You need, as Dr. Subina had very nicely shown in the photographs, you need to recognize some of the important signs, which includes retinal arterial or tortuosity, venous dilatation, and then you need to refer. And then there is another question that can the follow-up visits be reduced if you find TAR considering the current time? So I think if you go to the IROP Society guidelines, they have very nicely shown that how you can reduce the follow-up visits in these times. So you can visit that article, read that article, and you will get clear guidelines as to how the follow-up should be in these times.
If that guideline is difficult to access, then it's also that table on follow-up has been published in the IGO article on guidelines for COVID. So please look at that as well.
I have a question. It is regarding you doing laser in stage 4A ROP. I am sure some of these babies may not have required surgery. So do you have any data on that, where you could prevent surgery in 4A just by doing laser alone? Because long back when I was looking at the data from PGI, I had 30% of such babies who regressed with laser, even in stage 4A.
And I completely agree with you, Gaurav. And I think we have the data, we are yet to analyze it. That is something I was talking to my team about. It's not just 4A, sometimes very early 4B also regresses. So you are trying to buy time for surgery, or for some reason they are not fit anesthetically, and then you suddenly realize they don't need the surgery. You're very right, but we've not analyzed that data.
I think somebody has just published, I'm forgetting who, from our country only, and they have shown excellent success of 4A regression after laser. It's not a large series, I'm forgetting, but it is something the publication is just come out. So I'm just not remembering who. I just usually tend to look at.
and their group.
Okay.